Hello and welcome to the 2024 immunization update put together by sponsored by PSW. I'm Mary Haney and the faculty for this presentation, and this is my conflict of interest slide. Please know that I am a consultant speaker and get research support from GSK Vaccines. I also get research support from Dynavax, Novavax, and Takeda Pharmaceuticals. And then this presentation has been peer reviewed, and hopefully you will be aware of my conflicts of interest and be okay with the presentation. However, I have one other conflict that I want you to know about, or interest at least, is I'm a really big fan of vaccines, face paint jerseys. So I'm a big fan. All right, today we're going to talk about recent ACIP recommendations for childhood and immunization, and we're going to come up with vaccine recommendations for adults considering age and risk factors such as medical conditions. And then we'll summarize the recent changes to ACIP recommendations, including those for seasonal influenza vaccine, COVID vaccine, pneumococcal vaccine, and RSV vaccines. Let's start with Streptococcus pneumoniae. Some big changes have happened in this one. The vaccines are designed to prevent invasive pneumococcal disease. No, the vaccines prevent invasive pneumococcal disease. That is defined as detection of the bacteria in normally sterile body sites. So the incidence of the incidence in people 65 and older is 24 cases per 100,000 population. And then also there's pneumococcal pneumonia in people under age 65. That incidence is about, as shown at between 100 and 400 per 100,000 population. And once you're over age 65, though, look at how the incidence of pneumococcal pneumonia skyrockets to 800 to over 3,000 per 100,000. There are 4 currently available pneumococcal vaccines on the market, including 3 conjugate vaccines: the conjugate 15-valent, 20-valent, and 21-valent. And then you're all very familiar with the pneumococcal polysaccharide 23-valent vaccine. This is, I think, one of the important things to show you about the new pneumococcal 23-valent vaccine. And the proportion of invasive pneumococcal disease that is prevented with the 21-valent vaccine. So on the left-hand side, you'll see 19 to 64-year-olds who have a risk-based indication for pneumococcal vaccine. You can see on the left-hand side of this bar graph the coverage of serotypes by the 20-valent vaccine. And then over on the right side, you'll see the coverage of serotypes by the 21-valent vaccine. And then on the right-hand side, you'll see a percent of coverage in individuals 65 and older. And on the left-hand side of that bar is the 20-valent, and then on the right-hand side of that bar is the 21-valent. The point of this slide here is that the 21-valent has been specifically designed for adults, whereas the PCV20 is designed for both pediatric and adult immunization. So let's talk about what the recommendations are for these vaccines at this point. I guess, well, before that, I'm going to talk a little bit about incidence. One of the things I want you to know, sorry about that, is the incidence of invasive pneumococcal disease has generally been declining. You can see over on the x-axis of this graph that starts in 2007 and goes out to 2019 by year. You can see that the incidence overall is declining. And you can see the recommendations for changes in pneumococcal vaccine. Now, of course, the PCV13 is the subject of this vaccine, and that vaccine is no longer even available. It's not commercially available anymore. It's been replaced by the PCV15 and PCV20 and PCV21. And then yet another slide of invasive disease. And the reason I included this one is because I wanted you, again, you could very clearly here see that the incidence is declining. And like many respiratory diseases, although not, clearly invasive pneumococcal disease is not exclusively a respiratory disease. In 2020 and 2021, the incidence was low, but look at, there's a little blip back up right now. So this is cases in the antimicrobial, it's a network of geographically dispersed areas involved in infection surveillance. So it doesn't really have any vaccine information in this, but this is just as what is happening in invasive pneumococcal disease in the US. So let's start talking about PCV 15 and 20 in pediatric immunization. There's a universal recommendation for infant immunization, and it is currently, the recommendation is currently PCV 15 or PCV 20 in a series. So that series is at 2, 4, and 6 months of age, with a fourth dose given at 12 to 15 months of age. Immunocompromised children aged 6 to 18 years can receive at least one PCV 20, and then they need no other additional doses. If they had received previously the 15 or the 13, they can either receive a 20 or a PPSV 23. So this is that, and that recommendation is only for immunocompromised children. Otherwise, universal childhood infant immunization for all children with either PCV 15 or 20. Okay, pneumococcal immunization for adults has become a little bit more complicated because we have some options. We use pneumococcal vaccines on a risk-based recommendation, and it's for immunosuppressed as well as people with chronic illness. Future slide. Okay, those who we decided who's immunosuppressed, which include people with congenital or acquired immunodeficiency, HIV, renal failure, nephrotic syndrome, cancers, and iatrogenic immunosuppression, such as immunosuppression for control of an autoimmune disease, patients who have had a solid organ transplant. Other conditions that include that are indications for pneumococcal immunization include individuals with chronic diseases. And this is chronic heart disease or lung disease, diabetes, cerebrospinal fluid leak or a cochlear implant, sickle cell disease, alcoholism, or cigarette smoking. And then also, and I maybe even should have this in bigger font on this slide, all adults aged 65 and older. Okay, I'm going to start with the current recommendations for adults aged 65 and older. And I really like this this table that nicely summarizes the recommendations. If a person 65 years of age and older has not previously received any pneumococcal vaccines or PCV7 only, which was never recommended for adults, but you never know what happens out there in the real world. Option A is PCV 20 or PCV 21. Option B is PCV 15 followed by PPSV 23 within at least a year interval. For those adults who have received PPSV 23, and now they're 65 years of age or older, they should receive a 20 or 21 at least a year later. And then option B, of course, would be also to include the PCV 15. For anybody who has received a PCV 13. Now, historically, PCV 13 was recommended for individuals 65 and older. So you're going to run into cases like this. So because there have been changes to the pneumococcal vaccine recommendations, as you saw on the incident slide that I showed you earlier. PCV, if a patient, you run across a patient who has received PCV 13 at any age, you can give them a PCV 20 or 21 at least a year after the 13. And that's option A. And you can see that there's a pattern here with previous vaccination that there's about a year that's given, previous as an interval. And then you can also get PPSV 23 is option B. Now for people who received both a conjugate vaccine and the 23 before age 65, which again was a previous recommendation, now the patient is over age 65, you can give a PCV 20 or 21 at least 5 years after the last pneumococcal dose. And the other option under option B is you can read. If an individual has a complete series of PCV 13 and 23 after age 65, so both of those vaccines were administered after age 65, you may administer a 20. Now, this sounds like it is an impossible task to implement, but it's really not, because it's all about the age. Think about the patient. Has the patient received a 20 or 21 after the age of 65? And you can see that is the option A. And option B is always often includes either a 15 or a 20 or a PPSV 23. Now, likely your practice will choose vaccines to stock, and you're not going to need to stock all of these because you have option A and option B. And so you can make those decisions as a group. This is a similar table for individuals who have immunocompromising conditions. And here you can see prior vaccines are the same actually as those listed for people 65 and older. And again, if the person is unvaccinated, you would give a PCV 20 or 21. And if the person has received only a PPSV 23, which occasionally happens because sometimes people will receive a pneumococcal vaccine because of a medical condition and then become immunocompromised, such as a good example would be a cancer patient, maybe who has COPD. Example might be a patient with heart disease and then becomes a transplant patient. So that becomes immunocompromised. So PPSV 23 would have previously been recommended for them. So you kind of don't need the reason for why the vaccine history. You just need to recognize what the vaccine history is and implement these recommendations, which are very similar to the ones I just read. So I'm not going to go over them in detail again because that's not that interesting to listen to. But I urge you to keep these tables handy. And then particularly once you highlight which vaccines you decide to stock, you can make this much simpler. There are also recommendations for non-immunocompromising health conditions. And again, the recommendation is primarily based on their vaccine history, which you can use. And primarily it is option A, PCV 20 or 21, or option B is PCV 15, followed by a 23. If it's needed. And then below this, I listed what those chronic non-immunocompromising conditions are. So moving on to talk about RSV vaccines. RSV is respiratory syncytial virus. Respiratory syncytial virus is a really common seasonal respiratory virus. It's very contagious, and it's well known to cause hospitalization and bronchiolitis with wheezing in infants. But there is a considerable burden of disease in adults. And we know about the burden of disease in individuals 65 and older. And then we also know that there is a risk of hospitalization for adults with chronic illness, including heart, lung, hematologic, neurologic, diabetes, kidney, liver, disease, immunocompromised, and a variety of others. It is estimated that there is 60,000 to 160,000 hospitalizations for RSV every year in adults age 65 and older, and about 6,000 to 10,000 deaths annually in individuals age 65 and older. And this is the age group in which we have our best data. That doesn't mean individuals 60 and older are not at risk, or even other individual adults are not at risk, but rather we just don't have as good a data. We have 2 RSV vaccines available. We have a Pfizer bivalent and a GSK adjuvanted RSV vaccines. In general, the ACIP has recommended them using interchangeably and without really differentiating between the two. They both should be administered as a single dose, and both have demonstrated efficacy in lower tract RSV infection over at least 2 seasons for individuals age 60 and older. And so the ACIP has modified their recommendations slightly for the current season. And they have made a recommendation for a single dose of RSV vaccine is recommended for adults aged 75 and older. So a single dose for all adults 75 and older. For adults aged 60 to 64 with chronic medical conditions or other factors that might increase their risk of severe RSV, they should also receive a single dose of RSV vaccine. Please know that there are a few patients, although not great coverage, who received a dose last year. You don't need to vaccinate them again. They are good for this season. There are some adverse events associated with RSV vaccine, and I want to go over them because this is a relatively new vaccine. There's injection site reactions. A few patients have some systemic reactions and don't feel good for a couple of days. Arthralgias, myalgia, fatigue, and headache. There is no difference in serious adverse events with RSV vaccine compared to placebo. Remember that serious adverse events are those things like hospitalization and death. There does appear to be a risk of Guillain-Barré syndrome with this vaccine. And you'll remember that Guillain-Barré syndrome is a risk that sometimes happens following vaccine. And I have shown you here that the risk of the incidence rate ratio and the confidence interval for each of the vaccines. And here's the thing, though, and I put a little note on this slide too, is Guillain-Barré syndrome is rare. Therefore, uncertainty is high. You can see the size of the 95% confidence intervals that I present here. But the study, and there's also the study results are observed versus expected rather than actually matched cases. And the results are using claims data. So it's not a perfect study, but it's the best we have for right now to evaluate. Certainly the risk of Guillain-Barré syndrome following this vaccine is still very, very low. RSV vaccine is also recommended for pregnant individuals. But only the RSV pre-F or Abrezvo is the only vaccine that is licensed and recommended for pregnancy. And we're taking advantage of passive immunity by immunizing the pregnant individual, will then pass the immunity on to the infant late in pregnancy. And then the infant is protected from RSV, lower respiratory tract RSV early in life. So the ACIP has recommended maternal vaccination of RSV using only the RSV pre-F or Abrezvo from weeks 32 to 36 through the completion of the 36th week and seasonally. So it should be given September to January in most of the continental US, including Wisconsin. For the prevention of lower respiratory tract infection in infants aged less than 6 months. So let's talk about adverse events in pregnant individuals. Again, injection site reactions and systemic reactions did occur, but resolved in 2 to 3 days. The package insert will say data is insufficient to establish or exclude a relationship. However, a study was just published that showed observational real-world data did not find an association with preterm birth. There were more hypertensive disorders noted in immunized individuals compared to placebo, but it was numerically higher, not statistically significant. So now I want to present a little bit of information about passive immunization. We are using this strategy more and more by immunizing pregnant individuals to protect the infant. We do that for influenza, pertussis, and now we're doing it for RSV. You'll remember that late in pregnancy, maternal antibodies pass across the placenta to the fetus. And so IgG is actively transported across the placenta. And that typically happens late in pregnancy. And then those, you can see on the right-hand side of this graphic, those maternal antibodies protect against respiratory infections early in life of the infant, when the infant is very young and is not yet protected against vaccines himself. Then I also want to talk about another strategy for protection of infants. Nirsevimab is a long-acting monoclonal antibody with efficacy for the prevention of lower respiratory tract infection, of RSV. And this is administered just prior to or during the RSV season. The Advisory Committee on Immunization Practices has recommended for infants born for administration October to March. So we'd want to give it in October to all eligible infants younger than 8 months of age. And then for all eligible children born during the RSV season between October and March. Eligible children aged 8 to 19 months who are at increased risk should also get it second time for a second season. And that is primarily children who are really high risk. And it was children who were previously eligible for palivizumab. And then also added on were American Indian and Alaska Native children. And then this is the doses, 50 milligram dose for children younger than 5 kilograms, smaller than 5 kilograms, 100 milligrams for children who weigh more than 5 kilograms. And then it's 200 milligrams for the 8 to 19 months age group. And nirsevimab is included in RSV. A lot of hospitals have taken on or plan to take on administering this vaccine, this monoclonal antibody at hospital discharge for infants born between October and March. And then I assume a lot of this will be done in pediatric offices, but certainly pharmacists could administer nirsevimab with a prescription in Wisconsin because of the age of these children. And then I was so happy I could include this. Nirsevimab was 90% effective at protecting infants from RSV-associated hospitalization last season. RSV is something we really want infants to be protected against, and this is a very good strategy. And then next topic is COVID-19 vaccines. The leading causes of death still include COVID. I've downloaded this table and highlighted COVID. It's now number 10 as a cause of death in the US. And in 2022, though, these are the 2023 provisional data. In 2022, COVID-19 was the 4th leading cause of death. So we're making great progress as the population gains immunity. I also want you to see that COVID is still associated with a significant amount of deaths in the US. Remember that COVID-19 is a respiratory illness caused by SARS-CoV-2 virus. Symptoms look exactly like other respiratory infections, with fever, chills, cough, shortness of breath, fatigue, myalgias, headache, sore throat, congestion, nausea, vomiting, diarrhea, new loss of taste and smell, occasionally still happens. But those are the symptoms of most respiratory and viral infections. The risk of long COVID remains, but it seems to be decreasing. And particularly as we gain immunity in the population. This study was done and recently published. The risk was about 10 for long COVID was about 10 per 100 persons. And then Delta, it was a little bit less than that, but vaccinated people had kind of cut their rate almost in half. And then for Omicron, it was about 8 per person years. And then, but in vaccinated people, it was 3.5 per 100 persons. And in this analysis, 28% of the decrease was attributed to the era-related effects, or the era of which virus was which variant was circulating. So the pre-Delta, Delta, and Omicron, and 72% of the risk of the decreased risk of long COVID was related to vaccination. So another reason to talk to your patients about becoming back, receiving the COVID-19 vaccine is decreasing their risk of long COVID. The messenger RNA and subunit protein vaccines are becoming available. They target the JN.1 lineage with a preference for the KP.2 strain. You remember that the vaccines, Moderna and Pfizer vaccines, are licensed for children or for everyone 6 months of age and older, and the Novavax, which is the subunit protein vaccine, is for 12 years of age and older. Vaccine recommendations change frequently. Use appropriate vaccine formulations, and the CDC provided recommendations and schedules. At the time of this recording, the ACIP is just about to make the recommendation, but it's likely going to be a universal recommendation for everybody 6 months of age and older. And now I'm recorded saying that, and I hope my crystal ball works. And then let's move on and talk about influenza vaccines, because there's a bit of a change this year. Influenza vaccines are going to be recommended according to this quick list here. Enhanced influenza vaccines, high dose, adjuvanted, or recombinant, are recommended when available for the individuals 65 and older. If none of these are available, any age appropriate vaccine may be used. Avoid administering vaccines to those 65 and older in July and August. And so, of course, we want to make sure that their vaccine protection doesn't wane, particularly those at really high risk. We don't want them to wane before the influenza season is over. And then the big change this year is that the 2024-25 influenza vaccines will be trivalent. And the reason for this is that one of the B viruses has not circulated in humans since 2020. So we don't need to include it in the vaccine because it's really not presenting a risk to humans anymore. Remember that the quadrivalent vaccines included two A viruses and two B viruses. So the trivalent will be 2 A's and 1 B, and that will be the B Victoria, which continues to circulate in humans. Here's some examples of enhanced influenza vaccines. There's no standard definition of enhanced, but these, remember again, these are the ones that are preferentially recommended for those aged 65 years and older. These vaccines, this is a recommendation that it was also in place last year. So it's not new, but I think it's always good to have a reminder. The clinical benefit of these enhanced vaccines has been demonstrated in clinical trials and in observational studies as well, particularly with their ability to decrease the risk of influenza-associated hospitalization in these individuals age 65 and older. There's also some economic benefits. They may, depending on the season, they could actually even be cost saving, primarily because of their ability to decrease rates of hospitalization. But the use of enhanced influenza vaccines very likely is the cost of it is less than $195,000 per quality adjusted life year. So, and again, the economics really depend on the seasonal variability of the vaccine and the season, the severity of the season. One other recommendation that was just made this year is for solid organ transplant patients. Because of the nature of solid organ transplant patients living longer and longer, probably almost every pharmacy in Wisconsin provides care for at least one solid organ transplant patient. So they this year may receive high dose or adjuvanted influenza vaccine for solid organ transplant patients 19 to 64. This is acceptable, but not a preference by the ACIP. So it's just an option that's presented to immunizers and solid organ transplant patients. We can co-administer these seasonal vaccines. Consider that individuals 75 and older have a recommendation for potentially up to 3 vaccines this fall, including influenza, COVID-19, and most people over the age of 75 years will also need an RSV vaccine. They may be due for other vaccines too, including Tdap, shingles, and pneumococcal vaccines. The ACIP recommends co-administration of vaccines when they are indicated. Now, injection site reactions may be more common. And so all vaccines could be administered in a single visit, but use your professional judgment, like how likely are you to see, is this patient to come back and get additional vaccines? Yeah, I doubt that all of these vaccines would be available at the same time. We're going to have influenza vaccines before we're going to have COVID-19 vaccines, although COVID-19 vaccines are supposed to be arriving any day now. So this is a professional judgment type co-administration of these seasonal vaccines, and I'll leave it up to you and your experience. Given these ideas now, I want to spend a little bit of time talking about some cases. So here I present a truly fictional case. I have a retired 86-year-old female with atrial fibrillation treated with metoprolol and apixaban. She has a remote history of colon cancer. She lives alone, but her adult children check on her daily and assist with shopping. Her vaccine history includes influenza vaccine annually and COVID-19 messenger RNA vaccine. She's received 3 doses. So what vaccines are recommended for her? She, of course, needs a seasonal enhanced influenza vaccine. She'll need a seasonal COVID-19 vaccine, an RSV vaccine. She very likely needs a Tdap and a pneumococcal vaccine. From the buffet of choices, I would pick option A, and she also needs a zoster vaccine today and scheduled the next one in 2 months. How about some additional complications associated with this vaccine? What if she previously had received the live zoster vaccine? You're checking the WER and you see that she received a live zoster vaccine 12 years ago. You should still administer recombinant zoster vaccine series now. What if she had shingles 2 years ago? She could still receive the recombinant zoster vaccine series starting now. And then my third scenario, what if she was previously immunized with PCV 13 and or PPSV 23 at age 79 years? then she could receive a PCV 20 or 21 today. Okay, case 2. This one is going to be a 42-year-old married with 3 school-age children. He has moderately to severe Crohn's disease and is treated with adalimumab. Adalimumab is a tumor necrosis factor alpha monoclonal antibody, so you would want to consider him immunosuppressed. His vaccine history is he's received all childhood vaccines, including the hepatitis B vaccine series. He receives the seasonal influenza vaccine sporadically, and he's received 4 doses of COVID-19 messenger RNA, including a booster in the 23-24 booster. So vaccinating an immunosuppressed adult. There is an immunocompromised column on the vaccine in the vaccine schedule. And so he's at increased risk for complications of vaccine preventable diseases, but he's also at risk for poorer immune response to vaccines. And then we also have some age considerations as well as considerations for immunocompromised individuals. So here are the vaccines on the list. COVID-19. He should get a 24-25 dose when it becomes available. You could consider the HPV vaccine series due to immunocompromise. Recommendation is a shared clinical decision making for 27 to 45-year-olds. Now he is married, but a new sex partner is a possibility. And it is a risk factor for HPV infection. The vaccine series is safe and effective. So those are that's a conversation that you could have with this patient. And because he's immunocompromised, he needs a pneumococcal vaccine the vaccine choice and recommendation is very similar to those for age 65 and older, which we just went over. And he should have a seasonal influenza vaccine every year, and of course, use only inactivated preparations. Just to remind you, the live attenuated influenza vaccine that's administered nasally is licensed and recommended for adults up to age 49 years, but not for him because it should be only used for healthy adults. So he should get only inactivated preparations. Use the WER to check for TD or Tdap status and immunize if it's been at least 10 years since his last dose. Immunocompromised adults also have a recommendation for zoster vaccine. Individuals with inflammatory bowel disease have a risk for zoster that is similar to people 60 years of age and older. And that risk is even higher, which if he is immunocompromised, which he is. So initiate that zoster vaccine series today with a second dose in 2 months. Then I also want to talk to you about hepatitis B vaccine. Hepatitis B vaccine has been recommended for infants since 1991 and for adolescents since 1997. And it is now recommended for all adults aged 19 to 59 years. The need for protection against hepatitis B is important in individuals on anti-tumor necrosis factor alpha agents, and because they confer a risk for severe hepatitis B infection. Now, this individual has been vaccinated, and he has a history of hepatitis B hepatitis B vaccine series. We'll say it was documented in the WER. And please know that about 50% of those who responded to their vaccine series will have antibody to the hepatitis B surface antigen less than 10 when measured about 10 years later. But about 90% of healthy individuals will respond to a challenge dose with an antibody to the hepatitis B surface antigen greater than 10. If you just give them a dose, that's considered a challenge dose. And then you would consider them a responder and protected. Now, there's no reason to measure antibody to the surface antigen in all adults with a history of vaccine completion. There are some recommendations or considerations at least to to measure that antibody, the anti-HBs in some adults, such as many healthcare workers will have their antibody measured. Patients who are immunosuppressed might have their antibody measured. So here's a strategy that could be used. So he has documented completion. If we measured an antibody to the surface antigen and his antibody is greater than 10, document and no further action is completed. However, if you go to the right-hand side of this flow chart, and his antibody level is less than 10, administer a challenge dose and then measure another antibody. If that antibody is greater than 10, you're good to go. If it's less than 10, complete another vaccine series. However, you might want to consider one of the newer hepatitis B vaccines for that series, which are Heplisab-B and PreHevbrio. There is some evidence that of improved seroprotection rates when hepatitis B CpG, which is also trade name Heplisab-B, is given to individuals at high risk for poor vaccine response, such as individuals aged 40 and older or people with diabetes. There is also some evidence of improved seroprotection rates when using the 3-antigen vaccine, which is trade name PreHevbrio. Again, higher age, higher BMI, diabetes, or immunosuppression. So these vaccines might be an advantage for immunizing adults who are older or at risk for poor vaccine response. The newer hepatitis B vaccines include Heplisab-B, which is has a novel adjuvant. It is given on a 2-dose series at 0 and 1 month, and it is licensed for individuals aged 18 years and older, but it is not recommended for pregnant individuals. PreHevbrio is a 3-dose series and a three antigen vaccine. So it's the 3x3, I think. And it is a 3-dose series at 0, 1, and 6 months. Can be used in adults. These, the ACIP recommendation shows no preferential recommendations, but just lists these as options. I'm trying to give you this information as options as to why you might want to use one of these vaccines. What about people over age 60? Remember, I talked about a universal recommendation for individuals 19 to 59. People over the age of 60 should be vaccinated against hepatitis B if they could have one of these following risk factors: liver disease, HIV, sexual exposure risk, current or recent injection drug use, or anybody who wants to be vaccinated. And then risk of percutaneous exposure, which has not really changed over time, but are listed here. It's really interesting. People with hepatitis B over age 60, people with diabetes over the age of 60 years also is a risk factor. So individuals with diabetes are almost 2 times higher risk of evidence of past infection. So, but hepatitis B vaccine response is, as you know, decreases with age. There have been outbreaks of hepatitis B that have occurred in long-term care facilities, but these have primarily been traced to inappropriate use of blood glucose monitors. So, you know, we don't have a big need to go vaccinate all adults with diabetes who are over age 60. Maybe stick to that previous list on the list on the previous slide. This is where I was going to wind up. And for those of you with some travel, here we go with old Far Side cartoon about be a virus, see the world. Vaccinate everybody.